So good afternoon to all. As ma'am said, this is our last day of our session. Today we are going to learn about end of life care and medical ethics. This will be taken by Dr. Sreedevi Warrier. She is a palliative care physician and having more than 10 years of experience in palliative care. She did her certificate course in palliative medicine from Pallium India and fellowship in palliative medicine from Institute of Palliative Medicine, Calicut, and also she did MSc palliative care from Cardiff University, UK. And now she's heading the academic department of Pallium India. So we are happy to have you here, ma'am. Welcome and over to you, ma'am.
Thank you, Sister Shiva and Senior, and thank you everyone for being with us for this course of foundation course for palliative nursing. So as mentioned in the introduction, we'll be talking a little bit about end of life care as well as ethics. So I'll just start sharing the screen. Just give me a moment. Sorry, I was muted. Sorry. So we all know that this is one sure thing that we all can expect in our life, right? Once you are born, then this is a final common pathway for all. The pathway might be different. Either you go there in an hour, a day, few days, few weeks, but ultimately everyone is going to reach there. But we generally don't discuss about it due to many cultural or many myths related to death. But we know that it is inevitable, right? So any of you have thought about your own death? Anyone from this group? Have you ever thought about your own death? Have you discussed that with anyone in your family or with your friends, or at least you have thought about it? Anyone?
Good afternoon, ma'am.
Yes, sister, please.
When you're going to die, the fairness and honesty will be there, ma'am.
So have you thought about your own deaths sometime?
Yes, ma'am. Last year I was got corona, ma'am. I went to ICU.
Oh.
That time was in critical condition I felt, ma'am. So that time I was going to, I thought I'll die maybe like that. The situation is like that, ma'am. 5 days I went to ICU. Okay. Then they say for the ward observation, then I can be normal, ma'am.
Okay, that's thank you for sharing, and that's a great news that you are back to your health now. But yes, I understand that you have seen or gone through that difficulties of death, right? Thinking yes, about it, how my kids will be.
Correct, ma'am.
Yeah, thank you for sharing, sister.
Okay, ma'am.
Anyone else?
Sreedevi ma'am, we have a message in chat box from Sister Animam Peya. She says that she is scared.
Sorry, can you read it out?
No, I am scared of death.
Okay, yeah. Okay, got it. So everyone is kind of scared of death, but then ultimately we have to face it. And if we don't think about our own death, how can we be bothered about others, how others are dying, right? We don't really bother about. I have an experience when I asked some of the medical students during a program that they were all in the final year of their post-graduation, and none of them have seen a patient normally dying, like in other than in an ICU or without an ECG or without a CPR. None of them have seen a patient normally dying. So there is no concept of normal death. Death has become gradually a medicalized process. It's something like a procedure, something like a something which is more medicalized than or a medical failure than a normal process. So this is sorry, I skipped a few slides, I guess. I think I missed one slide. There was a case scenario in this. So that was a 67-year-old male who was found unconscious during in an advanced stage of illness. That was a scenario, and he was brought in an ICU and injected pressors multiple times. And then they wanted to check the ABG, so stuck the femoral artery multiple times to do the ABG. And then he's dying, right? He's in advanced stage and he's become unconscious. And so in the above, you can see it's a cardiac, end stage cardiac failure. So then everyone was trying as usual in an ICU to put a central venous catheter multiple times, not happening. And then performed chest compressions and then pushed breathing tube into his trachea and then given shock and finally pronounced him dead. Isn't it a common scenario in our institutions, at least where the paper place where you have studied? Have you seen this a lot? When a person is brought into the hospital, all these rituals happen and finally they say, okay, your father or your mother is dead. Any response in the chat? No. No one has seen this. I myself have seen this a lot when I was a student, where all these rituals will happen and finally they say the person is dead. And at least we have seen this in movies, right? And this is what's supposed to be a dying process for medical students also. They have, so when I asked them, tell me, what do you think about the whole concept of death? So for them, death is this. So they told death is about trying hard to get the lines in. If not, then do the CPR, then try to intubate, and still everything has been tried, not possible, then we tell them the patient is dead, patient is expired. So this is a normal mechanism that happens when someone is dying. This is not told by me. This was published in BMJ in 2012. So what are the principles of end of life care when it comes to palliative care context? So what we aim at is to ensure the patient is very comfortable appropriately. The patient should not be suffering with overwhelming symptoms or anxiety. As you said, I'm scared of death. Everyone is scared of death. Even there are patients who says that I'm not scared of that. I know that I'm dying of cancer, but my worry is about something else. But even if they say they are not scared of death, when the moment comes, they're all scared of, especially about uncontrolled symptoms. So when they share that I'm scared of death, we ask them, what are you that actually scared of? We don't know how death looks like, right? No one knows until you die. So they say, the process is scary. I don't know whether I'm going to die in pain. I don't know whether I'm going to be breathless. I don't know whether I'm going to feel something very anxious when I'm dying. So the anticipation of all these events makes them more scared about death. It's not the death per se is scary for people, but it is about that process, how it is going to be, how long it is going to be. Am I going to suffer? So then we usually ask them, will you be less anxious if we say that we can control all your symptoms? We make sure that you are going to be comfortable throughout the process. So that brings in a lot of relief in them. They know that they are not going to literally suffer and death, but they can understand that there is a team around me who can make me comfortable. So I know that I'm dying. I just want to be more comfortable. And what is the second principle? Avoid unnecessary interventions. These interventions include anything: injections, feeding, medications, unnecessary medication, unnecessary consultations, investigations. So we know that we at least many of you might have some experience in patients going through multiple CT scans or MRIs, even if we know that this is not working or this particular cancer treatment is not working, but still they have to undergo a lot of investigations, a lot of liver function, renal function. And then if you start asking yourself, What am I going to do with this? Am I going to change my treatment plan? If I know that the patient has a liver problem, am I going to treat it? If we are not in a position to treat the liver problem, then why should we actually send them or put them in the trouble of going through these investigations? Is something that we need to think when a person is dying. And review all the medications. So there is a concept that, okay, in palliative care, when the patient is dying, then you don't have anything to do. It's kind of chill because anyway, a person is dying. That's not the case. The care intensifies when someone is dying, because we believe that you can imagine if one of your relative or your loved one is dying with a lot of symptoms, lot of suffering that remains in our head for ages, right? We remember that with a lot of trauma. So I had my own aunt dying of end stage kidney failure. I was a student, I didn't know anything about palliative care. She literally suffered. Her death was in ventilator. She had a lot of symptoms. But although I have around 25 years of experience living with her, what remains in my head is that she died suffering and I couldn't do anything about it. I didn't know what is palliative care. I didn't know that these principles can be applied because I was a little bit young at that age. I was just doing my third year or fourth year of my graduation. I didn't know any of it. So what picture I have, still I have in my mind, is that she suffered to her death, although we knew that she's dying. So it's very important when someone is dying, reviewing the symptoms, the care intensifies. It's not that we are neglecting that person is dying. Okay, we don't have anything to do. Anyway, there is no medication, no feeding, no tracheostomy, no blood investigations. Easy to manage. No. The care intensifies when someone is dying, and reviewing every medication, I think periodically, because every hour things change. So we keep reviewing the medications. And very, very important thing, maintaining effective communication with the patient if patient is conscious and the family. It's very important to get them prepared for the event. You can't just okay, anyway this person is dying and that process will happen. No, there is a lot of communication work which begins far before the exact dying process, which will continue even after death, and ensure necessary support for the family and the caregivers. So what are the common symptoms? So when you ask a patient who is dying, what are you scared about death? As I told before, usually patients will tell you, I'm scared whether I'm going to die in pain. I'm scared whether I'm going to have breathlessness when I'm dying. Right? Is that the feeling that you had, Sister Karunya, right? You shared that you had COVID. Were these the physical issues that you were anticipating, either pain or, apart from your anxieties about your family, are these the common thing that you are thinking? Am I going to have pain? Am I going to die breathless? Anyone else can also talk.
My both lungs are affected with the corona, ma'am.
Yeah, so you were scared about breathlessness, right?
Yes, ma'am. Breathless is there, and fear of anxiety is there. Oxygen is not maintaining very well.
Yeah.
And in front of me, the ICU, two patients are I'm ventilated, ma'am. So I'm getting scared. Even though the situation will come to me also.
Yeah.
So it's very much tough. Getting out is very difficult to come out, ma'am.
Yeah. So not just in COVID, but when patients are dying, normally also, not a sudden death when someone is working and suddenly having a cardiac arrest and dying, but otherwise people are worried about pain, breathlessness, and as she was telling, anxiety, that we know that we are dying. So what is going to happen next? These are the problems that patients anticipate, and these are the common symptoms that we as palliative care people will see. Pain, breathlessness, noisy breathing. When someone dies, there is a noisy breathing. That's a very natural part of the dying process. Restlessness, some people will have restlessness towards the end, agitation and restlessness. You might have seen in ICUs. Some people will have nausea and vomiting, and most people will have difficulty in swallowing. Most of them, I think around 90% of them will have, and all of them will stop eating and drinking when they are dying. And some of them, if they are bedbound for a long period of time, they might have bed sores, incontinence of bowel and bladder. And sometimes we do see emergencies like stridor, seizure, hemorrhage, etc. So we'll take symptoms one by one. You have heard about the management of all these symptoms before, like pain session you had, breathlessness session you had. So we'll see how we manage these symptoms when someone is dying. So we know that we cannot just assess. The proper pain assessment cannot happen because the person might be dying. He may not be able to tell you out of 0 to 10 how much pain I have. So we have to change the assessment method a little bit. Sometimes we may have to assess from the patient's facial expression, whether the patient is showing some restlessness, whether the patient is moaning, groaning. So the conventional pain assessment may not work when someone is dying, but analgesics to be given according to WHO analgesic ladder. It's not that someone is dying that we don't need to rely on this ladder. We have all learned about this WHO ladder. So we have to follow the WHO ladder even when the patient is dying. And if the patient is already on opioids, we can always think of higher dose of opioids. And we know that when someone is dying, the urine output, you might have seen in dying patients, the urine output decreases. In the last few hours or days, literally there won't be much of urine. So we know that when the urine output is reduced, there will be accumulation of opioids. So we have to keep that in mind. So maybe we can reduce the medications frequency accordingly. Even if I have to increase the dose, I might not be giving it hourly. I may increase the interval as per the patient need. So the next symptom is breathlessness and noisy respiration. This is a very, very common presentation of some patients when they are dying. If you are, even if you are not in palliative care, when your own family members are dying in advanced stages or advanced age, you can if you get a chance, you can notice that there is a gurgling noise when someone is dying. Patients will tell you that my father or mother has a lot of sputum. He might be having a lot of chest infection because there is a lot of noise coming up. Then usually what people do, they end up in doing suctioning because when they know that there is a lot of secretions. But where is the secretion coming from? Can anyone tell me? It's written in the slide. Where is it coming from?
Throat, ma'am.
Yeah. Why from throat? Is it chest infection? Is it the upper respiratory tract infection? Or is it something else? So we are talking about patients who are dying. Where is that noise coming from? I hope at least some of you have seen people dying, right? Is there anyone in this group who have not seen a death, a dying person? Anyone? Should I tell everyone to switch on their videos? Because this is not helping because no one is talking. Until and unless you start interacting, it will be very difficult to go ahead with the session. I can hear only Sister Karunya and I think one more sister who typed in the chat. Yes, please. So I hope, is there anyone who have not seen someone dying? There might be, because there are high chances that you may not be dealing with patients who are dying. Have you ever seen the secretions like noisy breathing when someone is dying?
Yes, ma'am.
So where is that coming from? I've written that on the slide. You can just think about it and tell me. Are they able to swallow when you feed them when someone is dying?
No, ma'am.
So what happens to the saliva and other secretions in the oral cavity as well as in the throat or all through the GI tract? All these secretions will pile up. At least the secretions over the throat, the saliva which is being produced. The saliva doesn't know the patient is dying, right? It is being produced unless he is on some Parkinsonism or any other disease. They'll be having a lot of normal saliva. So they are unable to swallow this, right? Or spit it out. They are not responding. They are just lying down without any. So they are not moving their hands and legs. Same way, they cannot, their muscles of swallowing is also not working properly. So they cannot swallow or spit the secretions that gets pooled in the back of the throat. The term is called death rattle. It's like a gurgling sound. It's very noisy. You can sometimes we can hear it from the next room when someone is having death rattle in one room in a ward. You can hear it from 2 beds apart. It's very noisy, and you can see it is something similar to if you push water through a bucket, I mean air through a bucket of water, that kind of noise when air is passing. So there is a pooling of secretion in the back of throat, and patient is breathing through the nose and the mouth. So when the air passes through the secretion, that sound is coming out. So that's very loud. And what happens? The family will keep coming and telling you, sister, my patient is having some issue. There is a loud noise. He cannot breathe. He is having some chest infection. His chest is not clear. Please do suctioning. So what is needed? Suctioning is not the measure that is needed. What they need is explanation. Why? Where this noise is coming from. So there are a lot of studies telling that this noise is not bothersome for the patient. The patient will not have any issue from this pooling of secretions because the time is over. They're literally they're terminally ill. So the time where they can feel that discomfort is over from out of the secretion. So it's very important to tell the family suctioning can actually increase the distress because you are literally putting in a tube and poking on the throat. And any irritation to the throat will produce more secretion. So if you put in a suction tip, that will touch the back of the, near the soft palate or the posterior part of the oral cavity, and it will produce more and more secretions. So you don't need to suction it. So what can be done? Very simple nursing non-pharmacological method. Change the position to one side and just give gentle chest physio on the back, tapping on the back. So the moment you turn the position to one side, all the secretions will come out to the through one side. That within a minute the noise comes down very commonly. So it's very important to tell the family that why it is happening, where the noise is coming from, what can be done at home. So there are certain medications which can be used to reduce the secretion. The one is glycopyrrolate. You might have seen that in theater during the surgery to reduce the secretion. So injection glycopyrrolate can be used to reduce the secretion. Suppose patient is in a place where you can't just go and give injection. You can use the same glycopyrrolate injection medicine, just open that ampule and pour that medicine under the tongue sublingually, the same injectable glycopyrrolate that will reduce the secretion. You can use it 0.2 microgram 6 hourly. Maximum would be 1.2 microgram per day. So that is one thing that you can use. Then I'm mentioning about breathlessness. So that is the change in the respiratory pattern is very normal when someone is dying, right? The breath pattern changes. So we have all heard about chain stocks breathing. The breathing will be very shallow for some time, then they stop for a while, and then they take a very deep breath, then again shallow, and it will be more of an abdominal breathing than a chest kind of breathing. So that breathing pattern changes is absolutely normal. So we have to tell the patient and patient's family that there is a high chance that the breathing pattern changes. But if you feel that if the patient is having some discomfort from breathlessness, morphine is the drug of choice for end stage breathlessness. For any breathlessness, yes, but when someone is dying, it becomes more important to keep the patient as comfortable as possible. And as I have mentioned, avoid suctioning, and I've told why we should avoid suctioning. Any questions regarding this? Good to go to the next symptom. So some patients will be very restless and some patients will have myoclonic jerks, not very common, but in advanced cancer, we see a lot of terminal restlessness, not not very commonly seen in non-cancer prolonged illness, but in cancer, we see a lot of restlessness. So understand why the patient is restless. I hope you had a session on delirium, right? Why? So we'll see what is correctable. Is there anything that we need to be corrected? Is there any sodium issue, potassium issue? Is there any brain mets? Is there any constipation? Is there any urinary retention? So understand what is the cause for restlessness. But many a times when it is a terminal restlessness, usually it is irreversible. And what is the management? It's very important to be with the family at this time, because they'll be really worried when their loved one is very restless, taking up hands, pulling out sheets when they are dying. That's not a very pleasant thing to go through. So it's very important to talk to the family. And the drug of choice for terminal delirium or terminal restlessness is benzodiazepine. And if needed, we can add on, haloperidol. And if needed, we can add on a dose of benzodiazepines also. The primary drug of choice is haloperidol. I'm not sure whether in ICUs you might have seen a lot of delirium where they are usually sedated using benzodiazepines. That is not recommended. If you think that the patient is having delirium, first thing is to treat with an antipsychotic like haloperidol or quetiapine. But haloperidol is preferred drug of choice when it is terminal delirium. Above that, you can add benzodiazepine like midazolam or lorazepam, but benzodiazepine alone may increase the restlessness. Another symptom might be nausea and vomiting. Again, that's usually seen with cancers of gastrointestinal tract. Just see whether we can treat the treatable. And again, if it is not clear where this vomiting is coming from, there is no chance of obstruction, again, the drug of choice will be haloperidol. And there can be multiple causes. And we know that when someone is vomiting, when they are dying, you cannot give oral medication. So we recommend to use subcutaneous medication. When I say subcutaneous, the thing is that if it is subcutaneous, it is easy for them to manage at home. If you are putting in an IV line, very often they'll have to be hospitalized. Dysphagia and cachexia, very, very important, important for a nursing aspect of it. Because when someone is dying, they don't eat or don't drink, right? Initially, they stop eating solid food. Then they stop eating liquids also, or the semi-solids, and gradually they stop drinking. So there is a poor neuromuscular coordination. So there are high chances of aspirating. So what do you think about putting in a Ryle's tube at this stage? Because the patient cannot eat or drink anything, literally anything. The moment you, so I'll tell you a scenario, for example. 4 days back, one of my relatives called me and told their father is bedridden following a fall. He's in his late 80s. But even if he was in late 80s, he was very active. He used to have his morning and evening walk. Suddenly he had a fall. Following the fall, he became bedbound. He had a fracture on his right leg. So he's bedbound. Now, gradually, he has been deteriorating. He stopped eating, but he was taking fruit juices and the soups and everything. So they were okay. So from yesterday morning onwards, the quantity was getting reduced day by day. So they called me and told now he stopped eating completely. The moment we put in a spoon of water, he starts coughing. So can you come in and put in a Ryle's tube was the question that I got. So what do you think I should do in this situation? He was not responding. He's not talking. He's unable to talk. But when I called him, he's looking at me, but unable to talk. He was eating till 3 weeks back. He was drinking, but gradually reduced to few spoons since the last few days. But today morning onwards, he completely stopped drinking. The moment we give a spoon of juice or anything, he starts coughing. And the cough lasts for about half an hour. Then he's in severe distress. So what should we do? They asked me, is it okay to put in a Ryle's tube? So I would like to hear from you all. What do you think should be done? There is no right or wrong answer. It depends purely on the situation where you are working, where the patient is, where the patient wants, but what kind of conversation should be handled there?
Yes, we have to put
ma'am, we can rest you.
Sorry?
Yes, we have put
Yes, ma'am, we can insert rest you.
Yeah. Any other opinion? So why should we put the Ryle's tube? Is it because that he is aspirating?
No, ma'am, he's coughing more, ma'am.
Yeah. So coughing, essentially, I think he was aspirating a lot.
Yes, ma'am.
So what is, suppose I'm planning to put in a rice tube, what is my intention of that treatment? Whenever we suggest a treatment, there should be an intention. Okay, when I put in this, this is what I'm going to achieve. So one thing that I want everyone to think about is that, are we preventing aspiration when we are putting in a rice tube?
Yes, ma'am.
So do you think patients on rice tube don't aspirate? What about the secretions, the saliva?
They aspirate, ma'am. If
They
the feed
aspirate.
is
So
too
there are,
much,
yeah, not
if the
just
feed is too
feed.
much.
I think not just when you, even if you don't feed also, there is micro aspirations. Whatever saliva is being produced in our own mouth, they aspirate it. So even when the patient is in rice tube, even if we don't give any feed at all, the patients will aspirate. So rice tube is not preventing aspiration at all. That is one thing that we all have to keep in our mind. So I asked these questions to the group of doctors also. And initially they say, okay, we can put in rice tube, we should avoid aspiration. Aspiration is very problematic for the patient, etc., etc. But are we actually preventing aspiration? No, the patient will keep aspirating. So first thing, it's a very sensitive conversation, because when your loved one is not eating and drinking, that's going to create a lot of stress among the family members. Then I went there and I asked, he was not really well oriented, but he was, while calling, he was opening his eyes. If the patient is responding, the one question that I ask usually is, why can't you swallow? Is it because of some candida infection in the throat? It can be that. He may not be dying. But seeing him, I understood that he might be dying. But he was responding to some of the questions. So I asked whether he was hungry. He is not hungry. He doesn't want any feed at all. The moment a drop of water is going in, he's coughing like anything. So what I did, this simple thing, position change. He was just propped up. He was okay to be propped up position. He was not literally unconscious and lying down. So that the secretion was not getting pooled over there. The secretion was drooling out. So there were less coughing. And the second thing was about the concern of dehydration. What happens if he gets dehydrated because he's not drinking? And his urine output was quite okay. So what we did is, like, we started a subcutaneous infusion. It's it's not for treating dehydration, but to maintain the hydration. As he was not drinking and eating, just to maintain that hydration, we put in a subcutaneous route. But before I came into that conclusion, what I did is, like, thorough examination of his oral cavity, because I was thinking it might be due to an oral thrush that he's unable to. So the same symptoms can happen if he has an oral thrush. He may not eat, he may not drink, and a lot of secretions, cough, everything will be there, even if there is a candida infection. So I checked whether there is a candida infection. I checked the trajectory of illness. So he was getting deteriorated over last few days. So suppose a person is getting deteriorated in weeks, then probably his prognostication or end of life care is probably in weeks. If he is deteriorating over days, the person may come to the end of life care over coming few days. That's how we generally prognosticate. And I'm not talking about a person who had a road traffic accident and became bedridden. So this is a person who's been having multiple comorbidities and has been deteriorating over a period of weeks to months. So we have to make sure what trajectory he is on. That is also very important before taking these kind of advices. And it is a very sensitive area on artificial nutrition and hydration. It will not improve the situation. So what we usually see is that if we pump a lot of fluids through IV route, ultimately within a day or within few hours, the patient will start developing more secretions, more of a pulmonary edema, because the body is unable to push all these fluids out, because the body's mechanism is shutting down. The kidney is shutting down, the liver is shutting down, the kidney cannot push all these fluids out. So where is this fluid going? Around the lungs, around the heart and the lungs. The patients ultimately develop breathing issues. So even if they were normal, if you push a lot of fluids, they within an hour, within few hours or a day, they'll start developing the symptoms of breathlessness and secretions. And then they start developing, becoming edematous. that fluid buildup will be there, especially someone is dying. We are talking only about people who are dying. Their body is unable to process all the feeds and fluids that we are pushing in. And very important, even if they are dying, very importantly, so that day I checked whether he had any pressure sore. How is the skin over the back? Because he's in his late 80s, the skin was so soft and fragile. So he was already on an airbed. So I told the caregiver just to give gentle massage and Vaseline after the morning sponging and everything, to apply a lot of moisturizer. And another problem that we may encounter is the incontinence. There might be leaking of urine and as well as stools. And it is not pleasant. No? Someone is dying, a lot of people will come in, not during the COVID time, definitely, but when someone is dying, there might be visitors coming over to see. In our culture, we go and visit people who are dying and take their blessings and everything. So it's not very good that they smell of urine and fecal matter and they are soaked in urine. And it's very important to take care of their skin, even if they are dying. So it's very important to use either diapers, or if they are on catheter, if the death is not imminent, not dying in another few days, then catheter would be the preferred method. But otherwise we can keep in a diaper, so that the person is lying down with a lot of dignity. Not that when someone is dying and everyone is visiting, he smells. So that's not something which is acceptable. There are certain situations which come as an emergency where you encounter stridor or seizure or a hemorrhage. So understand whether it is reversible. Suppose a head and neck cancer patients. Okay, imagine a large wound on the side of the neck, which has reached almost the IGV, and the patient is hemorrhaging. We don't have anything to do. We know that the patient is going to die in a few seconds or minutes. So we don't even have the time to think about what are the reversible causes. Should we refer them to a hospital, etc.? There is no time. The immediate reaction should be to collect dark colored towels, whatever is available, and reduce the visual impact of the bleeding. That's something which we should do. What if it is a seizure? I can't just send the patient to a neurologist to evaluate why the patient is having seizure. Instead, I have to stop the seizure then and there. So I have to give medications like benzodiazepine. It's not very pleasant to see your loved one seizing, right? It's not a very pleasant sight for the caregivers. Even as medical professionals, it's kind of not a good scenario for us. So it's very important to stop that seizure then and there by giving necessary medication. So as a nurse, what you can do is like be with the caregiver, because caregiver will be panicking, they'll be very anxious, and there will be secretions coming out. And to make the patient comfortable without much of lip biting, and be with the caregivers is something which we our nurses do when this kind of situation comes. And these are some of the controversies that we now just discussed, right? One of this is, should we use pain medication? The patient is unconscious. Why should we use a pain medication? So for this uncle who was dying, he was showing some discomfort whenever the position is being changed. So when I was there, when I turned him to one side, he was showing a lot of expression, facial expression, grimacing. So we knew that he was in pain and he was having breathlessness. So I started him on a low dose of morphine subcutaneously. So the next day, some of the visitors came. One of them was a doctor. Then they asked, why do you give morphine? Because he is dying. Is it to hasten the dying process? Is it to sedate him? I don't know. This is purely for pain. How did you know that he has pain? He's barely talking. That's very, so when, especially as a nurse, you will understand, because you are going near the patient so many times, you will understand whether the patient is in pain or not. The moment you change the position, you lift a hand or a leg, the patient will show the facial expression of pain. So even if someone is dying, it's very important to give analgesics for pain management. There is a lot of controversies among artificial nutrition, hydration, but that is something that you need to think about. What are we feeding? Why are we feeding? Is it going to give a benefit for the patient, or is it beneficial for the caregivers? So that is one conversation I usually have with the family. So that day also I asked, they were all worried about feeding. Everyone was behind feeding. So I asked, for whom you are, what is the benefit that you are looking for? They know that their father is dying. They were pretty clear about that he is dying. There is no conflict regarding the death. They told, we need palliative care. We are not taking him to any ICU. We need to be with him. But without feeding, how can it be? So for whom they are feeding? Is it for, so then they started thinking about it, and then the daughter told, actually it is for my satisfaction. I want to be satisfied. I fed him enough. I'm not letting him to die in hunger. So literally it's the caregiver's satisfaction. So then I told, is it your satisfaction that you're giving more weightage, or is it the patient comfort that you are thinking about? So just think about it and let me know. Then I told them to stop the feeding, just see for half a day. Just don't give anything for half a day other than the subcutaneous infusion, and tell me how it went. So the next day told me the secretions, the noisy breathing has come down a lot. He looked more pleasant because his facial edema has gone down. He looked more like himself. He was looking good actually. So they called me in the morning. I was expecting a call telling that we need to restart the feeding. We need to think about the rice. But then she told, father is looking really clear today. So I asked, what do you mean by clear? His face is not puffy anymore. Now we can see him. He's not distorted. He looks very good now. And he's not making any noisy secretions now. And he's responding slightly better than last day. So these are the things that you need to negotiate with the family. It's not easy to give up on feeding really faster. So just give them bits and pieces. Then gradually we were able to stop the subcutaneous infusion also, but that took a day or two. The use of antibiotic when someone is dying, I really don't know what is the role of antibiotic when someone is literally dying. There will be raise in temperature, body temperature, because all the systems are shutting down. Your temperature regulation mechanism is shutting down. So there will be high temperature. And when you see this noisy secretion and the temperature, we assume that it is a respiratory infection. Start him on antibiotics. No, that's not the case. Both are different entity. The body is shutting down. So that's why the temperature rises. And that is why the noisy breathing is also happening. And there is a concept of terminal sedation, where we think if the patient is suffering, we have tried everything, all the medication, still the patient is suffering and he wants to die comfortably, we'll give sedation. Sedation is not high sedative that we are injecting. We'll keep him only at the dose where the patient can be as comfortable. And regarding the role of oxygen, we know that all the caregivers insist on giving oxygen. And we have to understand the normal pattern of dying. When someone dies naturally, I don't know whether you have seen your grandparents dying. I have seen a few, and I still remember their breathing pattern changes. I was so curious what is happening. Then my grandmother used to tell me that in the olden days, they used to count the breaths. So they have some counting, some techniques over there. And the moment they reach one particular count, it's the grandparents, they know that it's time. It's time for the prayers to start. It's time for the Ganga Jal if you want to keep it near, etc. So that was a normal process. Normally, the breathing pattern changes when someone is dying. It becomes shallower. But people generally think that he is deprived of oxygen. Shouldn't we give some oxygen at least? That's the usual question that we encounter. So again, the body is no longer in a state to process this oxygen. You are just pushing in a lot of air. The muscles are not breathing. The respiratory muscles are not working. None of the muscles are working. So where are we actually pushing this oxygen into? But if you think, okay, but I think the patient needs oxygen, just do an oxygen trial. Give oxygen for 10 minutes, because if the body is able to process oxygen, it will happen in first 8 to 10 minutes. The alveolar air exchange between the lungs and the inhaled air will happen within first 8 to 10 minutes. If you wait till 10 minutes, if you think that the patient is not improving, then there is no role for oxygen. So if you are still feeling okay, but I should give oxygen at least, then try an oxygen trial and make sure that if it is not, so ultimately who we are aiming at, the patient's comfort. And if you think even after 10 minutes, the patient is not becoming comfortable with this oxygen, it is better to stop. Because oxygen can make the respiratory path, the airway really dry, and it can be painful for the patient. And if at all possible, we discharge patients to home. That is again, how can someone die in a home? Yes, people can die at home. You have to make sure that they have all the medicines in hand, which needs to address their problems like pain, breathlessness, and everything. And some of the takeaway points is that morphine is the analgesics for managing pain when someone is dying. And when you are scared about respiratory depression, then you end up in not giving pain adequate pain control. So that is not really recommended. This we have already discussed. I'm not going into detail because we have one more topic to deal with. Sorry, yeah. Again, this is what we have discussed. The mechanical devices can be uncomfortable. So even if at all you have to give oxygen, it is important to give by nasal prongs, not by mask. And what if the patient, we have seen many patients on oxygen mask and the patient is sent back home. You just go home. That's not really not really possible for them to continue oxygen at home. It's not that cheap. Getting oxygen at home is also very expensive. There are patients who cannot afford the. So if you are doubtful whether oxygen is helpful or not, do a trial of oxygen. And discharging home, we are not simply discharging them home. We don't have anything else to do, so please go back home. That's not the case. We are preparing the patient as well as the caregivers. How? So what all things? So we call it anticipatory symptoms. There, we tell them that there can be secretion. Whatever I told you, we tell the same thing to the patients, exactly the same. They will understand. If we can understand, they'll also understand. We tell them that there can be secretions, there can be breathlessness, there can be pain, there can be restlessness. Everything we tell them, and we label all those medications, SOS, and then we train the caregiver how to give this subcutaneously and send them home. Or if orally or rectally, whatever route they are giving, we prepare them that these are the anticipatory symptoms and medications. And care at home, we have to convey that death is a natural process. First thing, we ourselves have to accept that death is a natural process. I don't know how many of us accept death as a natural process. We still think that is a medical event. It's not a medical event, it is a natural process. And most of the cases, I think we have around 3,000 to 4,000 patients in our care at any point of time. And our inpatient capacity is only 13 bed. Rest all are managing their symptoms at home. We don't need a 200, 800 bedded hospital because all of them are managing their symptoms at home. Majority of them are dying at home. So that is not something, and majority of them are from very rural, poor patients, as we say, uneducated people, but they manage these symptoms very well at home. So it's all about communication and preparing them how to take care of these patients at home. They need all this psychological support from our side. If you have a volunteer network, we can tell the volunteer, can you just give a call after 1 hour and just see how they are doing? But in our place, usually the nurses call them and ask, almost every hour they call, how is he doing? So there is a 24 hours number available where they can call and ask. So even if someone is dying, we have the responsibility to give the same care and attention. Not because that they are dying, you can just ignore them and okay, it is okay. Anyway, the patient is dying. It is okay to be in pain or breathlessness. I'll just quickly go through the ethics part of it, especially the end of life ethics in end of life care. Sorry. I'll just make it full screen. Sorry. Screen is pretty crowded, so I can't see. Not yeah. So this is one I mentioned about the trajectory of illness. So these are the transitions which happen in a chronic illness. So initially, when the diagnosis is made, so we can take any example, any chronic, congestive cardiac failure or renal disease. When they diagnose the illness, there will be some symptoms in the beginning and they still be undergoing disease modifying therapy. But later on, when they progress to their later stages, what happens is that the trajectory goes down and down and down. So it's a very gradual pathway. Unlike in cancer, sometimes we face a sudden deterioration in health. In case of chronic illness, the trajectory is very gradual. They come down, they deteriorate very slowly. So suppose they have an acute exacerbation, suppose someone in congestive cardiac failure, they had an event, and when they back home, they are not up to, so initially they might have been going for work and ADLs were normal. After each attack, the ADLs will come down. They become gradually dependent and ultimately becomes bedridden. This is the trajectory of chronic illness in most of the chronic illness cases. And these are the 4 cardinal principles of medical ethics. You might have all learned this during your undergraduate education, at least heard about these 4 principles. If not, kindly take a note of it. Autonomy, beneficence, non-maleficence, and justice. These are the 4 cardinal principles of medical ethics. So this we'll go through some of these scenarios, and I want to hear from you all quickly. This is a story of a 78-year-old woman with stroke, hypertension, and type 2 diabetes. He's very cachectic, bedbound, and totally dependent on all activities of daily living. And she was brought into your hospital with reduced urinary output and reduced oral intake. Exactly the situation that I mentioned about my own relative. And then the doctors diagnosed with UTI and end-stage renal disease. And then the doctor told, we have to take antibiotics and dialysis. But the patient was conscious. So patient told, I don't want any of it. The patient refused. But the sons, they are really well off, and they told that you have to go with the dialysis. So we'll just go through the questions. What will you do? Will you advise the patient and coerce or pressurize her to have dialysis? Or we'll just talk to the sons, and then that happens in our setting, right? We talk to the relatives, and the patient is taken for dialysis, and patient doesn't even have any clue what they are going through, and coming out, dialysis is done. Is that something that we are going to do? Or will you respect the patient's wishes, or will you just refer to a higher sense? What do you think about it?
Hello, ma'am.
Yes.
Yes, ma'am. We have to explain thoroughly to the patient that she needed to do dialysis. Until she have decided, we cannot take the patient directly to dialysis unknowingly.
Yeah.
So we need to explain her properly for that.
Again, patient is telling Sister Anu, no, I don't want dialysis. I understand. I might die if I don't do. I may die. I know that, but I don't want dialysis. Patient is conscious, no problem. So should we pressurize? I can see a comment on that. Yeah, the patient might be dying. Maybe.
No, ma'am, we cannot pressure her. We cannot pressure her.
So this is a very, there is no right or wrong answer, because we don't know, right? We don't know
Yes,
what
ma'am.
is
Yes.
the right and wrong. That is why we call it an ethical dilemma. It is a dilemma for everyone. So what ethical principle will help us to take a decision? So we rely on patient's autonomy. In our country, we don't respect this at all. We don't ask the patient what they want. Many a times we ask the family members and just start the treatment. So we have to respect patient's autonomy. Who makes the decision? In our country, I will say it is not even the family, it is the doctor who takes the decision, right? Doctor decides that you have to undergo chemotherapy. Doctor decides that you have to undergo dialysis, or doctor predicts that the patient is going to die, right? But there is some concept called patient's autonomy. So when you are caught up in some dilemma, right? If you are now, Sister Anu is confused, what should I tell the patient? Should I pressurize, or should I say, okay, your wish? That time you have to go according to the medical ethical principles. That is why this ethical principles are being made to help us to avoid errors or avoid any breach in the ethical aspects of it. So first thing, is the patient, has the patient have the capacity to make decision? What if the patient is delirious and telling no, or what if the patient is not even conscious? We don't know. What if the patient is having some psychiatric illness? So The first thing is to understand whether the patient has the ability to make the decision, ability to understand their situation, where they're able to appreciate the choices. So you have given the options, whether they understood it. Have you talked to them in their own language? You explained everything in English and they don't understand English. And then they say, no, 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 no. We don't know. So it's very important to understand whether the patient understood everything. Does he has the capacity to take a decision? And what should be the doctor's relationship with the patient? We have to respect the patient's privacy and confidentiality, and we have to tell the truth. And all the choices should be informed. You have to give, but you have gone through the communication session. You can't just tell everything in one sitting. In 10 minutes, everything has been told, and then the patient says no. So there is a way to communicate it, and whatever decisions we make should be a shared decision making. In our country, we involve the family members also, because it's a more of a family related culture. So we talk to the patient with the family, and then everyone sit together, and it should be a collective decision, not that the patient. So as I said, this should not be the way to ask the patient. You have given this problem and harms, risk, benefits, and told the patient which way you want to choose, A, B, C, and D, not this way. I hope I'm clear. Our intention is not to make the patient confused. Our intention, so if the patient say, I don't want dialysis, the first question personally I will ask is that, can you tell me more about it? Why didn't you want it? Then he come up with his, it might be slight. Sometimes patients will tell that I'm scared. Okay, then we can think about it. But in this scenario, the patient is literally dying. So I don't think because he has uncontrolled diabetes, hypertension, and he has underwent a stroke and in end stage renal failure. The reduction in urine output is because he is dying. So that is something that we need to understand in this particular situation. So I think we have that medical professionals, we think that I am an expert on healthcare, but the patient is an expert on his own life, right? He's an expert about himself. He knows about himself than us. So it's very important to have a partnership. I'm not telling leave everything to the patient, but to have a partnership and do a shared decision making. And patient autonomy is to be upheld at all costs in medical ethics. And what if suppose the patient has a dementia or doesn't have the capacity to take decision, then what should be done? Then understand who is the next of kin. Who is the decision maker? Is it the doctor? Is it this wife? Is it the son-in-law? Is it some distant relative? So who is the surrogate decision maker? And then talk to them. And beneficence. And in this patient, what I should consider is that, am I fixing what is wrong? The patient is dying. Am I going to prevent death forever? No. Am I effectively managing the disease process? What is the risk? What are the benefits? Is he going to suffer more? Is he going to get the benefits more? What if the patient has to go for dialysis 3 days a week and then the expenses involved, and what benefit he is going to get out of it? So that is something that I need to think about within me, that whether I'm thinking in terms of the best interest of the patient and what benefit I'm going to give the patient. So this is another scenario where a 20-year-old boy with metastatic osteosarcoma of lower end of femur with lung mets and anemia. And we know that the prognosis of this illness. He has a large tumor on the thigh and insist on getting operated. He told, I want to remove this. Even if I lose the leg, that is okay. Please remove the tumor. And both the parents and the patient is adamant regarding the operation. What should the surgeon do? So this is a place where I have to weigh between the benefit and the harm. What are the benefits? I'll be debulking the tumor. I'll be reducing the size of the tumor. It has some psychological benefits. The patient doesn't need to look at the big tumor and get worried. So there is a psychological benefit also. What are the harms? The extensive procedure, the pain he has to go through, the post-surgical time, the anesthetic complications. Already he is very anemic. So what am I going to achieve? So always weigh between benefit and the harm. So if there is no clinical evidence in that given situation, we don't need to, okay, but I am talking for patient's autonomy. Patient want the leg to be removed, I'm going to remove the leg. No, we have to think whether there is an evidence of good prognosis if I remove that tumor. So we have to rely on the clinical evidence, and we have to rely on not harming the patient. And what if there is a conflict of opinion among the family, and I feel that I should do the surgery, and Sister Shiva is telling me, no, madam, you can't do the surgery because it is going to cause more harm. So there is a conflict within the team. How will we resolve that? So it's very important to have that communication among the doctor, the patient, the family, and within your own team. So the first thing I need to think is that I should not harm the patient. And non-maleficence is the right of the physician. I have the right to choose that I'm not going to harm my patient at all. So I understand you might be confused whether I should talk for autonomy or I should talk for beneficence, I should talk for maleficence. That is why we call it an ethical dilemma. So it's very important to have your team on board, and the patient and the family, to understand what they are looking for, what are the benefits, how will we come into a conclusion. So communication is the key to resolve these dilemmas. So that is what, so there is no right or wrong answer. Even if I do surgery and what if the patient survives? Even if I don't do the surgery, that is, I am telling that I did the surgery because I believe in autonomy. And next day, another surgeon will tell that I'm not doing the surgery because it's going to cause harm. So we have to weigh everything. Which one weighs more? We have to go along with that line. Again, in this case, in this particular case, non-maleficence overrides the patient's autonomy, because even if you might have heard patients with advanced cancer telling us, please do some surgery and help me. So we cannot exercise autonomy there. We have to think whether we are providing some benefit because of the surgery. So there is something called a doctrine of double effect. So this is a very typical case. Ectopic pregnancy, and then you have to somehow do a salpingectomy. So your intention is not to harm the patient, right? Your intention was to help the patient by doing the surgery, because the patient might die of this ectopic pregnancy. So you are trying to help the patient. You are not trying to harm the patient. But as an effect, the patient lost something which is very important. So your intention should be clear. Your intention is morally good. You are not desiring the negative effect. Your intention is not to make the patient undergo such a very important or kind of very valuable thing, but your intention was to keep the patient alive. And sometimes when you do these kind of procedures, there might be some very simple example. When you when you gave antibiotics or an analgesic, when the patient came in with severe pain, you gave an injection of an analgesic and the patient died on the table, because we didn't know that allergic is, he said that he's not allergic to anything. Suddenly an anaphylactic shock happened. Did you intend to kill the patient by giving antibiotics? No. We were trying to help the patient, right? But anaphylaxis can occur to anyone. So your intention there was not killing the patient, but your intention was to help the patient. So this is called as doctrine of double effect. You can read the part in the yellow, a single act having two possible foreseen side effects. So there are two effects. One is good and one is harmful. Because I am scared of anaphylaxis, I decide not to give antibiotics in my medical life. That is not possible, right? I still have to give antibiotics. I still have to give analgesics. So that the fear of anaphylaxis is not should not prevent me from giving a particular treatment. So I think this must be the last one. A 57-year-old man with advanced metastatic carcinoma of lung. He's very breathless. He's later very advanced illness. Everyone checked him. No reversible cause for dyspnea. He's admitted to ICU and for artificial ventilation. And do you think that, so these were the questions that we need to discuss. As we are running short of time, I may not ask everyone to this. So here, what is something that I need to think? Something called a distributive gesting. Suppose there is only one bed And now we know that during this COVID time, how valuable it is to keep the beds, keep the ICU beds, right? Suppose there are only in few beds and it is a COVID time and this kind of patient comes in. Should I give that bed to this patient or should I reserve it for another possible recoverable COVID patient? So here we need to, the government is also thinking, right? Distributive justice. Whether I can help one patient where the prognosis is not at all good. I know that the patient is dying, but I still want to put him in ICU. Or should I want to help 10 other COVID patients or 10 other patients who are possibly going to live longer? So this is called a justice. So this is, are we allocating that precious resource of ICU? Am I using my resources within my hand in a wise way? Am I helping? Am I doing that in a right way? Are we considering the resources? So this is the fourth principle, that is distributive justice. This is a fair allocation of societal resources. And it says that majority of the resources like ventilators and ICU beds are consumed, 10 to 12% is consumed for people who are dying. It is just because that we don't accept death. We think that death is a medical failure. We think that we need to do something when someone is dying. That is why we are admitting this kind of patients. End of life care should not cost any ICU bed in the country, actually. So we need to understand whether the treatment is futile. Am I using it wisely? So this is a funny picture where you understand. When you are in ICU, dying is prohibited. You can't just die. It's not that case. People will die. It's not a medical a failure or a medical intervention that we are talking when we talk about death. I'm not getting into the detail because this is not something that might be important. I'm sorry, I've overshot 9 minutes, but I'm happy to take any question. I know that the ethical dilemmas are quite confusing, but that is why we talk about it. That is why the importance of communication among the patient and the family and your own team members should happen. I'm happy to take any questions if you. Sister Shiva, should I show the end of life care video once to the group? Maybe it won't take long time, right?
Yeah, I think we can.
You can ask some questions. Meanwhile, I'll just open that video.
Okay, thank you, ma'am. So, anybody have any questions? They don't have any questions, ma'am. So your presentation was clear. I think so.
I'll try to share that video if that is helpful. So this is a patient that we cared in our hospital. So this will just show you show you a glimpse of what happens when someone is dying in a hospice. What all can be done? What is the role of each person when someone is dying, including the family member? I'll try to share the screen. Let me see whether it works.
End of life care. As the end of
Was
life
it
approaches,
audible?
the goal of care.
Is it audible?
Yes, yes.
So this is a very short video. We'll just see this. Press the stop share button. I'm so sorry. Just I think that will be the last part of it. story. And this happened. This is how we take care of patients who are dying in the hospice or even at home. We do the same thing. We just train the caregivers and send them home, and we follow up through video calls and phone calls. So thank you for watching that, Sister Shiva. This is the last session, right, for this?
Yes, yes,
So
yeah.
you will have some feedback.
Yeah. Okay. So thank you, ma'am, for the excellent presentation. So I think the presentation was clear. So I would like to highlight few things. During the presentation, Madam has covered most of the things. So as I advise, says that nurses will be spending more time with the patient, especially in end of life care. The family members are nearing to the that lost their loved ones. So listening their worries and try to explore their emotions too. That is very, very important in end of life care state. It's always is very, very important is listening their worries, but especially in end of life care, we need to listen their emotions and we will try to explore their emotions. And coming to the nursing care part, as Madam was explaining how we will manage. We need to manage it. Symptomatic management is mandatory for the end of life care patients too. So coming to the end of life care situation, we need to improve the comfort level of the patient, try to maximize the comfort level of the patients, provide a comfortable position to the patients. So here, but I know here the skin care, maintaining skin care and administer medications and other things is very, very important. But here we need to keep it in mind. In end of life care situations, we do not interrupt too many times. So try to do it the things together. For example, if you want to change the position that for a early or 3 times, so when you give the medications along with that, you can try to change the positions. So that is you can keep it in mind. That way we can don't interrupt too many times to the patients. We can able to provide comfort to the patient. And another things, teamwork. So if you, during the conversation, if you found that any psychosocial issues within the family, try to involve the medical social workers in the team and explore their problems and try to solve their problems. And also we can try to meet their religious rituals also. If they want to meet some thing like that, you can arrange for that for the same. And so self-care is also important. You day by day you have to see, we need to work these type of patients. You need a good self-care. You have to share your that emotions, and you can share your feel with the loved ones or relatives or that family members too. So or listening music. So that the self-care is also important. So this is what I want to say this time during the end of life care part. So I think this is the last day of your course. Your feedback is also very, very important for us to improve the course. So kindly share your feedbacks